So welcome everyone. So we've got our global community webinar this evening. Tonight we're going to be focusing on the drug Mounjaro. So we're going to be having expert insights as well as personal stories. And we've got Sadaf Ali and Professor Tarek Hiwot joining us this evening. With great pleasure to have you here. And thank you ever so much for giving your time as well. I know it's an evening for you. It's going to be here today, 7 till 8 o'clock. And I know we hopefully have some people from around the world joining us. So it'll just be an hour. Thank you for those who sent in some questions. I have already sent them on to Sadaf, and she's popped some of those into her presentation this evening. But if there's any that we've missed off, we will have some questions at the end. I've turned most of the microphones onto mute. If you haven't already, please do that for us. And then we can have some questions at the end. I will do some photographs throughout, and it is being recorded tonight. So if you do miss anything, there will be chance after I've edited it for you to have another look afterwards. So what are we going to be going through this evening? So we'll be having a look at Mounjaro in great detail. We'll be giving a really good overview for you all. We'll be looking at how it can support overall weight management and your overall health. We'll be looking at some of the possible side effects and some of the safety considerations. And actually the best bit, I think, as well, is we've got Melissa here this evening, who's going to be giving a bit of a personal experience of how she's found the drug. Now, a bit of a caveat in there, obviously, everyone reacts differently to different medications. So her experience doesn't mean that that's going to be the same for everybody, but it's a nice way. It's nice to see somebody who is taking the drug and to listen to her experiences as well. And as I say, we'll have time for some questions at the end. Hopefully we'll be able to answer them all. If not, we can always get back to you afterwards if not. So welcome to everyone here, and some little introductions. So we've got Sadaf Ali and Professor Tarek Hiwot, and they're really our clinical experts from the Ulstrom highly specialised service here in the UK, and they provide our adult service. We've also got Melissa, who's our ASUK Wellbeing Coordinator, and as I say, she's going to be providing some of our lived experience for us this evening. So thank you all for coming tonight, and thank you as well for the three of you for also giving up your evening to provide some insights for us all. We're really thankful.
Catherine, I could start answering some of the questions in the meantime.
Yeah, that would be brilliant. Thank you, Tarek.
So I have, thank you all for actually sparing also your time to join us. And really, it's a great pleasure to be with you. So I think I have a few questions, Catherine, kindly forwarded, raised by you. First question is, why aren't all patients with Alström syndrome on Mounjaro? I mean, it's a very good question. If it is, effective, then everyone should be on it. So I think there are certain things it's important to know. Part of it, even though, this is medicine licensed primarily for people with diabetes or chronic weight gain of excessive nature with complications. So the NHS NICE approval, it has certain restriction. And the other thing also, some people are already controlled with other modalities, so they don't actually need to be on Mounjaro. I guess, Sadaf, your slides looks ready to roll. Is that right?
Yeah, just need to click on slideshow and you're there.
Yeah.
Fabulous.
Yeah, you can go now. Yeah. We'll go back. We'll come back to the questions later on.
Fabulous. Thank you both.
Lovely. Thank you very much. And I apologize for technology failure. It lets me down all the time, but I'm really glad that it's working fine now. So hi, everyone. Thank you very much for the invite, and thank you very much for giving me this opportunity to talk about what I love talking about, which is weight loss in Alström syndrome. So I'm academic clinical lecturer in University of Birmingham, and I've spent 3 years while I was doing my PhD with Professor Professor Hiwot, trying to understand some of the metabolic aspects of Alström syndrome, and I'll be sharing some of the experiences that I've had whilst I was doing my research and kind of whilst I work along the lines of metabolic medicine and obesity, and using Mounjaro in people that have obesity and type 2 diabetes. So I have put a slide on what I'll be talking about today. I'll give you a little introduction about the medication, how it works, the effective dosing. Then I'll talk about some evidence base around the efficacy and use of Mounjaro, some safety profiles, some cautions and contraindications, and I'll briefly touch upon the UK regulations around prescribing Mounjaro for type 2 diabetes and obesity, and I'll talk about the NHS England eligibility and the prescription pathway, and then I have put some slides together for some of the frequently asked questions that you kindly forwarded before the webinar, and I'm very happy to take the questions if you'd like to interrupt me during the presentation or after the presentation, and Professor Hiwot, of course, is happy to answer any questions as well. So to start with, what is it? And there is a lot of hype about this medication outside of its use, where it's required for people with type 2 diabetes, as well as weight loss. So essentially, it is a once weekly dual GLP-1 and GIP-1 receptor agonist, which is indicated in the UK for weight management and for managing difficult to control type 2 diabetes. To understand how it works, it's important to understand the pathophysiology of these hormones in people that do not have diabetes and obesity, to try and understand how these hormones help in effective diabetes control when they are given in the form of injection. So essentially, there is a photograph on the right of the slide which tells about the normal physiology in someone that doesn't have obesity, in someone that doesn't have diabetes. So essentially, GLP-1 and GIP-1 are two important hormones that are produced from your intestines in response to having a food, and they cause sometimes they produce an effect which is called an incretin effect. So what incretin effect is that these hormones increases the release of insulin from your pancreas under normal circumstances when you eat food, which is called a glucose dependent release of insulin from pancreas.
Sadaf, you're not moving your slides. Are you able to?
Yeah, so I am still on the first slide.
Okay.
Picture.
Go ahead, sorry.
So essentially, what these hormones do is they increase the release of insulin from pancreas, which helps to metabolize your glucose and prevent postprandial glucose exertions in normal person of diabetes and of obesity. They help to reduce the production of glucagon, and they slow down gastric emptying. Now, people that have diabetes, they have blunting of this incretin effect. So their body doesn't respond to the GLP-1 and GIP-1 the same way the body of someone responds to that doesn't have diabetes. So the effect of it is that there is reduced glucose dependent release of insulin. It also causes inadequate suppression of glucagon. It affects the metabolism of your fats, your proteins. Alongside it, it causes postprandial glucose exertion, sometimes also called post-meal related hyperglycemia, and also reduces the satiety signaling in your hypothalamus. So essentially, it overall causes poor glycemic control, and it causes you to eat more, and it causes some of the implication that people have that when they develop type 2 diabetes. Hence, when you provide these hormones exogenously in the form of injections, they help to reduce the stomach emptying. They help to increase the release of insulin from your pancreas and help in the metabolism of your glucose and prevent postprandial glucose exertions. So how does it help with your weight loss? It reduces your appetite by acting on your satiety and appetite regulating center in your brain. It slows down the stomach emptying, and hence it causes the sense of fullness. So you feel fuller when you have only eaten a small amount of food. Which naturally reduces your caloric intake and naturally helps to reduce your blood sugar levels by slowing down the absorption of glucose from the food that you've eaten. It increases the energy expenditures and it activates the receptors that boost your metabolism and energy use. It improves the insulin sensitivity in your body, and the GIP-1 component of the injection help not only to increase the effect of the GLP-1, but also has a role in metabolism of fat in your body. Now,
sorry, Sadaf, we're still on the front page of your presentation.
Oh, is it not moving?
No, it's still on the. I don't know if you want to go to slideshow. Because we're still on the first page with the injection picture on.
Can you see this one now? Next, well, how does Mounjaro support weight loss? Or is it
no, not yet.
No, we're still on your first, like the front.
That's very odd because it moved from the introduction one to this one, and then now.
No, we've always just been on the first one.
Yeah.
We've always just been on the picture of the Mounjaro injection.
Tell you what, will it be easier, Catherine?
Oh, wait a minute, it's moving now. Go on, move up. Yeah, we're on support weight loss now. Sorry, there we go.
Bear with me.
Yeah, it seems to be moving now, I think.
So how does it support the weight loss?
Yes, yeah, there we go.
Now it's moving.
Oh, amazing. Okay, thank you very much.
Thank you.
So essentially, now a few lines on the dosing and the titration of the medication and how it's done. So you start at a small dose of 2.5 milligram once a week, and you do it for about 4 weeks. This is just to give your body chance to get used to this new medication. And then you increase in increments of 2.5 milligram every 4 weeks until you have reached either the maximum dose of the medication, which is 15 milligram, or you have reached the maximum tolerated dose that your body tolerates without giving you major side effects. If you have missed any doses, and if it's been more than 4 days that you're late on having a second dose of the medication, then you basically omit the dose of that week altogether and you take the next dose on the particular day of the week. However, if it is less than 4 days, then you can take the dose when you remember, and you can then take the following week dose on the same fixed day. And the medication comes as a quick pen, and it's a monthly pack, and a single injection has 4 doses. And some of the other points to remember for some of the people that are insulin, the injection sites is a subcutaneous injection exactly like insulin, and you advise to rotate the sites, and you can use various sites including abdomen, upper part of the thighs, and upper part of your arms. And if you have severe persistent GI symptoms, then you pause the escalation and you step back to the dose which you tolerated. And the key whilst you're on the medication is to maintain the reduced caloric intake diet and to try and incorporate some form of physical activity and set realistic goals. Now, I will move on to some of the evidence base behind the medication. I'll talk about some of the trials specifically that are focused on the weight loss benefits and benefits in people with type 2 diabetes. So essentially, right from the start, initially, this drug was trialed to look at the efficacy of the medication for people with diabetes. And what they noticed was that not only there was excellent glycemic control in people, there was this additional benefit of weight loss, and hence it led to designing weight loss trials in order to look at the effect of the medication specifically for the weight loss. So the first trial was in 2022, which was purely focused on weight loss benefits of the medication in people that were overweight, over a BMI of 30, and they did not have diabetes. And it was a trial that ran over 72 weeks. And during that trial, there were dose-dependent weight loss benefits, and with every increment of the dose, there were progressively increased weight loss benefits. And as you can see, people that used 5 milligram dose managed to lose 15% of their body weight. And with the dose increment to 10 milligram, the weight loss benefits were more, going to about 19% of their body weight loss. Between 10 and 15 milligram, there wasn't a massive amount of difference, just varying from about 19% with the 10 milligram dose and only slightly higher to about 21% with a 15 milligram dose. And in comparison to placebo, which was just the diet and lifestyle, there was just 3% body weight loss in people that were on this trial. More than 5% of the weight was observed, at least 85% of the people that were on the 5 milligram of dose, and it was 91% in people that were on higher dose, dose of 50 milligram versus placebo, which was 35%. Then some trial, where now they extended the trial slightly. Now they used it in people that had obesity as well as type 2 diabetes, and the results were more or less the same. A 10 milligram dose led to 12% weight loss in people with diabetes and obesity, and a 15 milligram dose led to a 14% weight loss. The weight loss was ever so slightly less in people with type 2 diabetes in comparison to people that purely had obesity with no complications and did not have type 2 diabetes, but still the weight loss was still significant, with reaching to about a 15% weight loss in people that were on a 15 milligram dose. Again, a very important point that I like to kind of touch upon here is that the effect on glycemic control are observed at a slightly less dose. People have effect on glycemic control and in their HbA1c at a dose lower, as low as 2.5 and 5. But the effect on the weight loss are observed in slightly higher dose, such as 7.5, 10, and a 15 milligram. So SURMOUNT-3 trial, so essentially this was where they had a group of people, and they the group of the people had a intensive lifestyle and a monitored intensive lifestyle and dietary intervention for about 12 weeks, and they managed to lose about 5% of their body weight. Following this intensive diet and lifestyle, they were randomized to a group receiving Mounjaro and a group that was not receiving anything. And what they noticed was that the group that was randomized to not receiving anything after intensive diet and lifestyle, and after successfully managing to lose some weight, they gained weight in a 72-week period when they were randomized to not receiving anything. However, people that were randomized to receiving Mounjaro had an additional 18% weight loss. Not only they maintained the weight loss they achieved with intensive diet and lifestyle, but they also had additional weight loss on tirzepatide. So in combination, people that had intensive diet and lifestyle for 12 weeks and a 72-week period of tirzepatide in total lost about 25% of the body weight. Now, the 25% of the body weight is basically a number that matches the amount of the weight that you have when you have sleeve gastrectomy, which is a kind of a weight loss surgical procedure. Um, um, so again, a non-invasive way of losing weight with intensive lifestyle and having this injection in comparison to something called sleeve gastrectomy, which is a fairly invasive way of losing weight. Then this was followed by a Surmount 4 trial in 2024, where they, after 36 weeks of open label tirzepatide trial, where participants were on tirzepatide for at least 36 weeks, the participants were then randomized to not receiving anything and receiving the tirzepatide. And the conclusion from the trial was that withdrawing tirzepatide led to substantial weight gain in the group that were randomized to not receiving tirzepatide. And hence, the conclusion of the study was that obesity and the weight loss medications such as Mounjaro and Ozempic should be taken as any medication, such as diabetes medication and blood pressure medication, where you do not stop the medications if your diabetes has a better control or blood pressure is a better control, but you rather continue these medications over a period of time. And early this year in International Congress of Obesity, there was this data shared about the longer term outcomes over a 3-year period in people that have been on tirzepatide or Mounjaro, where there was sustained weight reduction over a three-year period in people that continued on Mounjaro, and it also delayed the progression to type 2 diabetes in people that had obesity and that were pre-diabetic in comparison to placebo. So that was a little bit about evidence base behind Mounjaro. And now I'll briefly touch upon some of the side effects with the medication. So common side effects: nausea, vomiting, constipation, some abdominal cramps, which are mild to moderate in nature and mainly are during the dose titration period, and they are mainly self-limiting. Pancreatitis is a rare side effect, and you should always seek medical attention if you have a severe intolerable abdominal pain, because the medication delays your gastric emptying. It may affect absorption of your oral medications. So something to be kind of mindful of, especially if you are on older generation anticoagulant medications. Contraception, it's advised that you use additional contraception whilst you have been started on Mounjaro at least for 4 weeks, and after each dose titration. This is because with delayed gastric emptying, there is effect on medication absorption. So in order to increase the efficacy of the medication, it is advisable that you have 2 different methods of contraception once you are on the medication. The risk of hypoglycemia: if you are on oral hypoglycemic medications and you use Mounjaro, the risk of having low blood sugar are less, except for if you're on a medication such as glucoside and insulin. Then it's advised that whilst you're on Mounjaro, because it will lead to better diabetes control. So hand in hand, you should be down titrating your insulin whilst you're up titrating your Mounjaro. And again, if if you're having some side effects where it's reduced your appetite and you're not keeping up with your hydration, there's always this small risk of you being dehydrated and not eating enough. So always to be mindful of to keep yourself hydrated and to continue to drink to about up to 2 liters of water. But again, I'll take that advice with a pinch of salt because every patient is different. Of course, if you heart is not working effectively and your kidneys are not working effectively, then you should always ask your clinician about the amount of the water that you should intake whilst you're on a Mounjaro, rather than following a generic advice of having a 2 to 3 liters of water whilst you're on a medication. Some contraindication and cautions. If you have hypersensitivity reaction whilst you have had the first dose, then this is something you should be mindful of to kind of whether you'd like to continue with that in case you have some sort of an allergy to any excipients in the medication. If you have had a previous episode of inflammation of pancreas or pancreatitis, then again you should be mindful of whether this is something that's really indicated. It's to be avoided in people that are pregnant during breastfeeding and to discontinue if you're planning pregnancy. And it is not advisable to be used in people with type 1 diabetes. I'll briefly touch upon where we are with regards to the NICE indications and the local health board pathways for giving permission or authorization for this to be prescribed. So essentially, it was NICE that published its guidance and approved its use around December 2024, where NICE recommended that this is something that can be used for managing patients with obesity as well as type 2 diabetes. Just bear with me. This was the diabetes guidance, which came a little earlier than the guidance around managing weight with Mounjaro. So essentially, the guidance around using the medication with people with type 2 diabetes is if you are on 3 medications with inadequate control of your diabetes, including metformin and 2 other oral anti-diabetic medications, and if they're ineffective and you have intolerance to them or they are contraindicated, and alongside you have a BMI of 35 or over, then this is something that can be considered for you. People of South Asian ethnicity or Afro-Caribbeans, Middle Eastern, Black Africans, these are some of the people where there is a slightly higher risk of development of type 2 diabetes and insulin resistance. So the BMI thresholds are slightly lesser than the BMI threshold of 35 to basically use these medications. The guidance on using medication purely for weight loss came a little later, was published in December 2024 and was last updated in September 2025, where essentially if you have a BMI of 35 and over and you have at least one weight-related comorbidity, which include either blood pressure, dyslipidemia, obstructive sleep apnea, or cardiovascular disease, or type 2 diabetes, then this is something that can be considered beneficial for you. However, there is a lot of variation on people getting it, and there's a lot of variations from region to region, because there is something that NICE approves on the basis of the evidence behind the efficacy of any medication, then essentially it goes through these chain of events. It goes through variety of regulations and approvals. It goes through the local health boards, and before the set pathways are put in place, looking at the target population, and then the funding gets approved for the local NHS trust before it starts prescribing the particular medication. And then even then it is scrutinized to a greater degree, especially in the initial days when a new medication gets approval to be prescribed at a particular NHS trust. And a lot of the times the pathways that are set at a local NHS trust for this medication to be prescribed may be different than to the NHS England or NICE guidance, because it all then depends on the commissioning bodies and the funding they have at the either at the local NHS trust or at the local commissioning bodies. And hence the reason there is a variation around from region to region with people that get it and the people that don't get it. I have now put together some slides for some of the questions that were kindly sent across. So why aren't all patients with Alström syndrome on Mounjaro? So first of all, we know that Alström syndrome is an ultra-rare condition, and being an ultra-rare condition, there are no large-scale clinical trials, and there is and it's less likely that there will be a large-scale clinical trials to look at the efficacy of this medication on patients with Alström syndrome. And the access is restricted by licensing and funding rules as well. So mainly the use of medication in Alström syndrome is experience-based and some evidence-based. We used semaglutide, and we looked at weight loss benefits and glycemic benefits in patients with Alström syndrome. So consolidating on some of the experience from using Ozempic in Alström syndrome before. And also being only prescribable at a specialist center, at the Birmingham Center. So these are some of the limitations around the use, and hence you probably may have noticed that it's prescribed for Alström syndrome only at Birmingham Center rather than sort of a practice at other regions in the UK. Then moving on to the second question, why some patients on semaglutide and some are on Mounjaro? So we know traditionally semaglutide is a GLP-1 agonist only, and Mounjaro is dual GLP-1 and GIP-1 agonist. And the trials show that Mounjaro leads to greater weight loss and glycemic control benefits. The choice of the medication again depends upon the licensing availability and tolerance. Now, talking about some of the benefits for Alström syndrome, improving obesity, help with their metabolic control. There have been trials to show is benefits in people that have fat in the liver, and then there have been published trials to show the beneficial effects of the medication in people that have fibrosis, liver fibrosis, and as well as reduction of the cardiovascular risk and insulin resistance. So although there are no Alström related specific randomized controlled trial, but the medication has been extremely effective in counteracting some of the metabolic implications of the disease, and hence the benefits for patients with Alström syndrome. Why some patients do not lose weight on Mounjaro? So again, there is it's dependent on variety of factors. It's different from one person to another person. And again, it depends on what's your baseline weight at the time you have been started on the medication. Genetic variability also has a role, and there are some other factors such as your lifestyle factors, and how it will have an effect on your brain regulatory circuits that control your appetite and your satiety. And alongside, there are some other factors as well. Say one person may have a better physical activity levels and may have a better diet than other person that may not have that degree of physical activity and may not have a similar diet and may have a higher weight. So the person one may respond altogether differently to a person two, although they both will have Alstrom syndrome, but the response to the weight loss and sometimes the glycemic benefits will even vary between one Alstrom patient to the other Alstrom patients. And also we have to bear in mind that once the BMI crosses a certain threshold, then the effects of the medication are slightly lesser than to the BMI threshold of 40 and 45 and less. And hence some of the variations from one patient to another patient. What hormones does Mounjaro impact? So we already talked about this. So it mimics the GIP-1 and GLP-1 hormones in your body. It increases the release of insulin and it slows down your stomach emptying of food. It reduces your appetite and impacts on satiety centers and appetite regulation centers of your brain, and it changes the way you look at food and you think about food by affecting the neuronal circuits and neuronal pathways in your brain appetite controlling centers. How does it affect your obesity? We talked about it, that there's been an average 15 to 22% of weight loss in SURMOUNT trials, and this is something that's been observed in real life as well. Improves your HbA1c, your lipid profile, your liver fat, liver inflammation secondary to fat, and it reduces the risk of weight-related comorbidities, and it has a overall cardiovascular benefits. Some of the side effects and management. So there are common side effects, which is nausea, vomiting, diarrhea, and constipation. And I completely forgot. I was about to put up a very useful slide which shows you a food plate, and there has been a very useful article that was published in Journal of American Medical Association, which is a patient-centered article, and all it talks about is evidence-based guidance to patients in a very simple language, talking about some of the side effects and how to manage your physical day-to-day activity and what your food plate should look like whilst you're on the medication. Essentially, you should eat smaller, frequent meals. You should keep yourself hydrated. Your protein intake, in order to prevent muscle loss and in order to achieve maximal weight loss benefits, and at the same time not lose your muscle mass, you should have at least 20 to 30 grams of protein per meal. In case you are feeling sick and nauseous and you cannot manage that 20 or 30 grams of protein per meal in the form of meat, poultry, then you can always switch to high protein yogurts, high protein milkshakes, which are easily available in the markets. And you should try and have some healthy fats in the form of nuts, some fruits, and you should have a good intake of fiber in order to prevent constipation, which can be very debilitating in some cases, because if you're not eating well, then of course it will cause you to be constipated, and it can be sometimes very nasty. So increasing your fiber intake in the form of some fruits, greens, fibers, vegetables, you can try and prevent that medication side effect. A little bit about the research and future directions. There's been SURMOUNT and SURPASS trials where there is a very strong evidence base in efficacy of the medication for diabetes control and for obesity. There are ongoing trials in patients with obesity and type 2 diabetes, and a more long-term trial over a 5 and 10-year period, and hopefully with time we'll have more evidence coming through about the sustained cardioprotective as well as renoprotective benefits of the medication. Although there are no dedicated randomized control trials, but there are case reports emerging, and and it's less likely there are ever going to be any randomized controlled trials. But I'm positive with evidence base and with case reports emerging, we'll have a very solid and strong evidence base to continue to use the medication for benefits for patients with Alström syndrome. What if the GP hospital won't prescribe? Again, in many regions, it's only licensed only for patients with diabetes. NICE guidance is evolving. The NICE published its guidance around the benefits of using the medication with obesity towards the end of last year. And many times for it to go to the local commissioning bodies and get the funding approved, the process can sometimes take about a year or 2 years time. So some of the regions may already have started prescribing it. In other regions, maybe the dedicated weight loss clinics are prescribing it, and hopefully with time there'll be maybe more wider use of the medication with an emerging evidence base for the efficacy of the medication. And one of the other way of getting the medication will be via trial participation. There was a question around alcohol and Mounjaro. There is no absolute contraindication whilst you're on Mounjaro for alcohol intake. However, alcohol can worsen some of the GI side effects, and it can affect your glucose metabolism. Therefore, it's best to either avoid or to reduce the intake to minimal whilst you're on the medication. Foods and drinks to avoid. Again, anything that's spicy, fatty, large meals. We know the medication works by reducing or slowing down your gastric motility. So if you're having a big meal, a spicy meal, a meal that's full of fat, it will cause you to be more uncomfortable and will give you more reflux, will give you more problems. So if you stick to smaller portions, clean eating, more fiber, lean meat, you can prevent some of these side effects. And it's always encouraged to have a balanced diet with low refined sugar, high fiber, and high protein in order to have the maximal beneficial effects of the medication. Yes, so that takes us to the end of my presentation, and with a little overview of the medication and some of the asked questions. And with this, I will stop sharing.
Thank you very much, Sadaf. Excellent presentation. There are a few questions actually coming through. Has Mounjaro been approved for children in the UK or elsewhere? I think the answer is not yet. Our child will be 10 years old next. Again, we're working with group in Bristol actually who manage young children with obesity, and they have treated children younger than 16 years of age, but outside the license. And in fact, we're putting the case report actually to publish them, working with them. So at this point, I think people will be reluctant. It's outside the license. And of course, not every medication, as a doctor, especially both managing patients with rare disease, we follow license. Sometimes we think the benefit outweigh the risk. Then it's something perhaps the doctor might consider, but it is outside the license, and most doctors may not consider it. Jen, your hand is up.
No,
we can't hear you. You are muted.
You were off mute a minute ago. You did do it. I saw it check. That stop. Yep. Go on. Oh.
We can't hear you, I'm afraid.
Can you pop it in the, have you got the chat function? You type it in the chat function. Sorry, Jane. Oh, you have. You have. Wait a minute. You're at the top. Wait a minute. So JJ was on semaglutide and weight loss happened. Then just kept weight stable, moved over to Mounjaro and only keeping weight stable. Is this normal with AS? He's been on both meds for a few years now.
Well, is it normal for AS? It's a very interesting question because not that many people are on semaglutide and switch to tirzepatide or Mounjaro. I think the benefit clearly, especially people have lost significant amount of weight, because maintaining weight itself is an achievement in its own right. Otherwise, weight naturally, as we get older, it goes up, unless we do something about it. So I would say, that's expected, Jen.
All right, is that okay?
Sorry, can I just ask just a follow-up?
Please do.
To my question. So I understand that it would be off license and off label. So I guess my question is we know that already. What would you suggest we do to try to get our children and get the medical professionals perhaps more comfortable that they might be willing to go off label or off license? Is there anything, I don't know if it's different in the US versus UK. Sorry that I'm out of breath. I'm just walking all around the conference here. But I would appreciate any advice you would have. I'm sure, I think Simon would as well. Thank you.
Well, thank you, Edward. I think in some way, one of the things, because even though Mounjaro came now, but we had this exenatides and families actually from early on. So we compared them and published them really in peer-reviewed journals in Alström syndrome, because when it comes to evidence to convince regulatory or payers or even clinicians, if they see it in a peer-reviewed paper, they do have much more actually attention to it, because it counts as an evidence. Of course, the unfortunate thing is, even though we have shown significant improvement with semaglutide and liraglutide in allosterone patient, it's only adults. So I think for adult patients, that evidence is the only evidence we have for syndromic actually obesity. People can have different interpretation, and I think, for example, the cholesterol-lowering medication statin is a good example. People who have familial hypercholesterolemia as a genetic condition, so even children will have high level of cholesterol. Of course, the best would be really to address them before actually the furring of their arteries. So it took some years actually for pediatricians to use statins, and when they were able to use, they could only stick to actually simvastatin. Of course, that has changed in the last 15 years. So I'm afraid we may follow that path, but I think it varies from individual to individual. I mean, in my circumstance, I look after people with rare disease. For most of the conditions, we don't have licensed treatment, and we don't also expect to have a randomized control study. So I will sit down with the families and say, this is what I think would be the benefit. This is what the similarities with this condition. And, this is the potential risk, and we don't know the full benefit. What do you think? I think if mutually agreed, then the next thing is convincing actually people pay for it. So I suspect, this sort of thing, especially for children, it has to be taken on an individual base, because we don't expect actually to the study be done, and let alone in allosterone even. I think studies may come up to 12 years of age, but anything younger than it would be a big ask. I don't know if I answered your question, but it's just my personal opinion.
Yeah, no, thank you. We've got a question. I think it'd be tricky to answer, actually. Is Mounjaro available in New Zealand? If not, what is the best alternative?
Well, yes, it's a tricky question, Catherine. I haven't looked at, and
no, I don't think we'd be aware exactly where in the world Mounjaro is available.
Yeah, I mean, Wegovy is a good product in its own right, and if one is available, then that would substitute. It's only Mounjaro is slightly more enhanced, and those are, I think, when we came to market, it became a wonder drug, and in fact we end up actually with a massive shortage for a few years.
Right, thank you. I think we've gone through most of the questions. Melissa, would you like to tell us a little bit about your experiences of Mounjaro? If you just go off mute for a second. I think you're on mute at the minute, Melissa. Let me see if I can. Oh, there you go.
Oh, am I done? Brilliant.
Hey, yeah. So tell us a little bit. When did you start Mounjaro?
Yeah, so that's where I kind of do want to start. I want to take you all back
Thank
kind of
you.
18 months ago to what my health was like then. And I will say now, I will tell you some things I would eat before, and I am not pleased with what I ate before, but that was before Mounjaro. So 18 months ago, my diabetes was out of control. I was around 114 when I was testing on a morning. Sometimes my blood sugar would be off the monitor, they were so high. Before I went to sleep, I would happily eat 2 packets of Pringles, or I would eat a whole large pizza and still be like, where's the next pizza? I could eat a 300-gram bar of chocolate and again think like I would like some more chocolate. So my food messages were very high. In February of last year, I was hospitalized because of the doctors were worried I was entering into diabetic ketoacidosis. And that was probably my wake-up call to something had to happen. My weight was not a good weight. My liver, we were worried that I'd be entering into scarring on the liver, and like I say, my diabetes was uncontrollable at that point. And I think at that time I just started insulin. I was not happy that I was on insulin, but I thought I'll give it a go. But insulin didn't seem to be impacting at all, so we had to have an intervention. So March of last year, I started on Mounjaro, and it's really changed my life for the better. So now my diabetes has gone down from 114 to, the last time I had it checked, it was 49. My liver has gone back to normal. My liver's the healthiest it's ever been. I've lost around 26 kilos, which is just over 4 stone. And something else, before I was on Mounjaro, I also suffered with atrial fibrillation that I'd had since 2013. And the last time I went to my Birmingham clinic, which was January this year, they told me that my heart was no longer in atrial fibrillation. And it's not been a year without challenges. It's been a year of learning what foods my stomach can tolerate, and I really identified with some of those side effects of feeling nauseous and the stomach cramps. I'm on 10 milligrams now, but in terms of quieting down the food noise and stopping my cravings, it's been a real game changer. So before, if I thought about a kind of food I wanted, I would have to eat that food, or I would be really fixated upon it, and I could eat a lot of that food. My hyperphagia was really strong. I never felt full. So I think that's one of the big learning challenges that I've had on that on since I've been on Mounjaro, was learning what full means, because up until last year I never knew what full meant. It's been limiting portion sizes, because again, I could just eat forever. I don't think I ever was full before. So that's been a challenge, is learning what I can eat now comfortably. And I think that the first time I was like, oh, I ordered a pizza and was like, I'll eat this pizza, and then ate a couple of slices and was full, was a real strange moment for me. But I definitely have really worked with the Mounjaro, and it's not just the drug. I think the drug is amazing, and like it's called a wonder drug, but I think it is also looking at your lifestyle, making some healthy changes, upping the fiber. Also, on a psychological standpoint, it was taking the blame away from myself. I felt I had a lot of self-blame and criticism for having to go onto insulin. I felt like my body had failed me again. And I felt powerless. I felt like I had no agency or responsibility for my life. I thought I'm just going to get iller and iller. And it was the shock of, doctors saying your organs could shut down, you could go into a coma, and, that could be it. I think, although I thought they were just trying to scare me at first, when I did accept and believe them, I thought, actually, I need to make these changes. I need to move more. I do have so much responsibility for the quality of my life. I meditate regularly. I accepted that being on insulin and Mounjaro wasn't actually a bad thing, that if that's what it took to help manage my diabetes, then that's what it took. So I kind of accepted it was part of the cure, rather than part of the problem. And now I wouldn't look back. Whether, there's still other doses that I can go up to, but at the moment my blood sugars are normal and they're well maintained. And sometimes they might be a bit higher if I eat unhealthily, but now it's a choice. It's a birthday, let me have a treat. Or that they're my choices. I'm not governed by food anymore. Like, I control food rather it controlling me. And I think that's been the biggest change in my life. And it was a real, I know Mounjaro impacts so differently on everybody, but it's been a real game changer in my life. And it was so nice to actually hear that I'm touch wood, that I'm relatively healthy, and it's a case of maintaining, and it's a case of it's really given me the control back of my life. So yeah, I think it can be a really great medication to go on. It helps you change your life. It helps you quieten down that food noise, and it stops you having some of those unhealthy conversations that can lead to binge eating behaviors and lead down that unhealthy path. So I'm a massive advocate for it. It's not to say that when I went up to the 10 milligrams, it took my body a long time to adjust to that. It took around 3 months for my body to adjust to that dose, and I did have stomach cramps and I did feel sick for a majority of that time. But I think, again, it's having those great clinicians that we're lucky to have at Birmingham that told me, like, trust the process. It just might take your body a bit longer to get used to this level of medication. So it was trusting that process and sticking with it when I felt ill. I found a really great protein based cereal, which is called cereal, which is high in protein and low in carbohydrates. And I limited carbohydrates. I cut down on them a lot and upped fiber and everything. So Mounjaro as a drug, it really helped me. And initially I thought that I'd struggle injecting myself and I'd have to have some sighted assistance for that. But again, I have to really say how excellent all our clinicians are at Birmingham. They taught me on a really cool squidgy strawberry, which I really wanted to take home. They showed me how the injection would work. They showed me safely how I can attach the needles to my insulin pen and my Mounjaro pen. And because I can't always, tell if the liquid's coming out because I can't see it, we worked a lot on my other senses on knowing the smell, knowing how it felt when the injection went in. So actually, the Mounjaro pen is something I administer on my own. I can do it, I pick the day that suits me, and I can do it then when it works for me, not just when I've got someone sighted on hand to help. So it really gave me a lot of independence. And like I say, it's turned that food voice down that was so loud before. It's been such a game changer.
Right. Thank you, Melissa, and thank you for such a wonderful personal insight. Really, I'm obviously wonderful to have Tarek and Sadaf here to give an overview of the drug, which is wonderful. But to actually hear from yourself who's taking it and really to give us a real honest viewpoint of how it was for you and how it is now, I think is wonderful too. And do you still get some of the side effects now, or are you kind of seeing that you're kind of past a lot of those now?
A lot of them, I think, as was said in the earlier presentation, it's very dependent on food. So
right,
I kind of notice now that I suppose I'm better at listening to my body, whereas I'd have, if I think of the Chinese I had for tea last night, it's it's really bad. I should have had like a salad or something. But no, I had a Chinese, and the Mounjaro did not like the Chinese, which is fine.
Oops.
And what is good at is when you eat something that doesn't agree with it making you think I shouldn't eat that in the future.
Okay.
But I think it gives you the choice. Like, I ate the Chinese, I own that,
Yeah.
and I felt poorly as a result of it. So
You kind of knew how you were going to feel, really, didn't you? You
yeah,
were just testing yourself.
Yeah, and I think it gives you your control back. Like, before,
Yeah.
I would have eaten all of my Chinese last night, but whereas like with Mounjaro, I was like, oh, I'm full now, and I stopped eating. Whereas
Okay.
I would never have felt that before. I would have eaten everything, and then been like, right, where's dessert? Where's the prawn
Yeah.
crackers? What else can I order? Whereas like last night, the different, I still felt ill, but I stopped when I needed to, and I didn't feel the need to like go back and have anything else. So I think it's really good at telling you like what you're not tolerant to. And I will, if I've had a really unhealthy meal, which I do still have, it doesn't stop all of your food habits, but I think I feel the toll of it on my body, and you think, was it worth it? Did I need that? And I think it's good at helping you like own your choices. I would be lying if I said I felt brilliant today, because I have not felt brilliant today, but that's my fault. So it's really good at helping you own your choices and take responsibility in your life, which I never really felt before. I always felt like, oh, everything's just happening to me. But having Mounjaro has really helped me take ownership, and I'm thankful for, although I'm not thankful for today, but I'm thankful for it, and it helps me make a lot of more sensible food choices.
Having that control back sometimes, isn't it?
Mm-hmm.
Definitely. Well, thank you all for the wonderful presentations this evening. We are running over just slightly, so I shall just quickly finish off, and then you can, let me just have a look. Right, can you see my slides? I think you all can, can't you?
Yes, we can. Yeah.
I'm going to say, don't start playing up technology with me. So we have our global database, which is a really quick and easy contact form. If you haven't already completed it, please do. This is for people outside the UK, because we have a really comprehensive database in the UK, but we'd love to connect communities and researchers together outside the UK. There's a QR code on the screen at the minute. I can also send the forms across to you as well as a Google form to complete. We also have the Global Patient Registry, which is a more in-depth viewpoint of your health and well-being and all of your sort of clinical information, really, for researchers to look into in more depth. So we have that one there if you haven't already completed. We are now on TikTok as well as Facebook, so please go and have a look and raise awareness and connect with us. We've got lots of information on the website, www.alstrom.org.uk. We've got the medical handbook, our latest news, research papers, and we've got clinical guidelines. Please do let us know if there's any topics you would like to hear about, and we will do our best to meet your needs. So please do keep in touch. And I would just love to say thank you for everybody for coming this evening. I know we've run over time slightly, and thank you. Oh, let me get back on, because I have gone completely onto a different computer now. Stop sharing. There we go. And thank you so much to Sadaf, Tarek and Melissa for giving such a wonderful overview, and for your insights, Melissa, because that was wonderful, and for all your wonderful questions as well. So it's been lovely to see all of you from all over the world. I know we've got lots of people from all over the place with us this evening. So thank you ever so much. And I hope you all have a good evening or a good morning or afternoon, depending on where you've joined us from. So thank you ever so much, everybody. Thank you. Bye-bye for now.